Can we get a microphone over there as well to somebody? I've got two here. I'll do these two and then I'll get one over there. Whoever had their hand up over there.
I was one of the people that was on the fore, the sceptical end. And in a way it's a shame that the table up there wasn't at the very beginning of yesterday morning, because it would have changed my view of it completely. Because we've got the principles, the aspirations, we've now got the senior buy-in. All we need now is the robust plan to say, this is what we're going to do. We've got the pathway agreements, so I think that's a great big change that we've actually got from the 2 days.
Hi, I'm very optimistic to hear what's been described. I guess an observation is we've got an opportunity to think about user involvement in quite a different way as well. And I'd just be interested in people's thoughts around how particularly patients and carers can be involved in this structure that you're describing.
So perhaps if I could start off the comments on that. I agree there's a real opportunity to think very differently about that, and again, don't want to harp on too much about it, but my experience elsewhere, where we've done things in a rather different way to really use the expertise that users and patients have to shape cancer services, absolutely crucial. And to go beyond the deterministic. So I'm sure that we can look to colleagues from third sector organisations, voluntary sector organisations, charitable organisations to help us as on behalf of the sort of provider chief execs. I put together this proposals for how this thing will work, but clearly that's one of the things that needs to be there, along with further thoughts about teaching and education and also research, as well as the clinical service, because all these things add up to the whole.
So we had one over there, yeah?
I'm really heartened with the agreement and the commitment by the panel, but I just wanted to raise one particular issue. It was at the table that we were on, that was the issue of prevention, because as a consultant in public health, I've been really concerned that along the pathway that we've talked about, we don't include that as part of this as well. I think, I wasn't here at Mike Richards' presentation yesterday, but I think if our outcome is to reduce mortality, I think world-class services will contribute to that, but I don't think that alone will reduce our mortality rate. So I do think there's an issue around if we want to meet those outcomes, the prevention agenda. And I'd very welcome the provider board actually taking that on board as part of its remit as well within its own trusts.
So as a former director of public health and still a fellow of the Faculty of Public Health Medicine, of course I agree entirely with that. And I think that this is not something that we've struggled with elsewhere. We've wanted to do, but I do think these new arrangements give us greater opportunities for interactions with local authority bodies and wider bodies who in many ways have to be the lead on this sort of thing. We can play our part from the NHS, and I think these arrangements give us a more focus to those sorts of relationships.
I'm pleased to report that CCGs are taking their public health duties extremely seriously, and where possible are investing in upstream prevention as far as possible. And I know they're working very closely with local authorities. In certain instances, CCGs are even investing with a leap of faith, knowing that the successes, if you like, will be reaped by local authority and an improved, healthier population for whichever area they're commissioning. But beyond that, though, I think CCGs have got an anxiety that with public health functions moving over to local authority, there is some danger in losing that expertise and getting that intelligence which drives commissioning decisions. It is important, however, that we do understand what drives CCGs to a certain extent, and it isn't just that public health function from local authorities, but remember that the whole notion of CCGs is that it's clinically led, and the 12 CCGs in Greater Manchester probably represent somewhere around 10 million consultations going on in about 500 plus small providers, which the intelligence from those are feeding each CCG And it's that depth of knowledge that general practice particularly gathers around its registered population, of which they see 90% at any given time, which then also enable them to provide that service along with the community providers. Now, beyond that, there is another conversation I've been having, saying, well, what's the role of all providers, not just primary care providers and community providers, but what's the role of secondary care providers and tertiary care providers in promoting population health-based outcomes? And I'm going to ask Tony to think about that one.
Certainly, if we had a newly appointed colorectal surgeon in a district hospital, let's say had that population had a 50% 5-year survival, where we really want to push it up to 60%. I don't see a problem in that consultant's job plan or personal development plan to say, look, over the next 10 years, we want you to work towards improving the survival for your specialist side, colorectal cancer, to 60%. Now, if I was a surgeon, how would I go about doing that? Well, I would push primary care physicians to increase the take-up with the screening programs and early referral. And that could be done, it would take a number of years, but it could be done by educating the GPs, campaigning locally for patients to take up the colorectal cancer screening. In low take-up practices, that consultant could work with those GPs and say, look, what can we do to push that up? I know that GPs listen to consultants. If we organise meetings at our hospital, certainly get an excellent attendance if we take going through clinical problems. So what I'm really saying is I think hospital consultants do have a big role to play in improving take-up with screening, helping with local campaigns, and I'm sure we can make an impact locally on our own population.
Can I just, if you indulge me for a minute or two, I think what Raj has drawn and Tony's drawn attention to is the difference between public health as a profession and public health as an activity. And public health as an activity is something which I believe we all are responsible for. Can I just also say that I think that in thinking about the bit of work I've been asked to do, well, the reason that I think I would want to do this is that what I've heard, and I really would want to take away from this session, is a commitment not to keep on talking about these things in abstract terms, but to do something, which I think is the thing that we've lacked over the years. It is that moving from nice cosy discussions, abstract interesting discussions about public health or IOG to actually making a difference on the ground in a way which has been done, but it hasn't been done at a fast enough rate. So the only reason I'm happy to take this on at the behest of the Chief Execs is because I think that's what we're about to do. And I think what this discussion has, over the last 2 days, has moved us, I hope has moved us from, is let's talk about it, so let's do it.
I'm not sure if there are still colleagues here from local government. I've been saying to the 12 CCGs in Greater Manchester that the health and wellbeing boards that's being established must be seen as an opportunity for a two-way relationship with local government. I think many people in local governments see it as the opportunity to democratise aspects of the NHS and to exert their influence on the NHS, but it's a two-way street. With public health moving over to local government, it does give us, I think, a much clearer opportunity to hold to account performance around the preventative measures that we need to have in place. We've recently started to pick this up at the Cancer Network Board. We've shared something fairly similar to the data pack that you received on day one with the Health and Wellbeing Boards, and we've asked to go along and attend their board meetings. So we will pick that up with them. I think today we've probably been far too passive, and whilst we're quite keen to performance manage issues like 62-day pathways, we're probably a bit more passive in response to the preventative measures and the success or failure of them. The 10 local authorities in Greater Manchester operate as the single AGMA arrangement. And we've been very successful in getting into their economic development strategy, the Greater Manchester strategy, health as an item on their agenda, which is fairly unique. And we've managed to persuade them to look at the economic drag that ill health has on the population of Greater Manchester. So this is an issue that they are taking very seriously, not as an ancillary issue to pick up once they've done all their other local government duties and responsibilities, but seen it as a core part of their delivery agenda for the future. And I think there's going to be the challenge for the CCGs at local level and operating with the Greater Manchester arrangements to make sure that we hold them to account for what they've got to deliver on our behalf there.
We've heard very clearly, and it's with great excitement really, that this leadership and provider board that you're talking about, do you envisage that you'll run alongside a commissioning board, or do you envisage that the CCGs will directly input to you?
This would be really interesting if I asked myself to say the same or different things. I would imagine we would need a complementary set of arrangements around commissioning that would sit alongside what we've described around the provider board. Clearly there will be a trick to ensure that both those groups or sets inform each other at critical junctures. But I think the value of the provider board, we really could start to get under the skin of some of the issues as Chris has described. But I don't think it would work well at all unless we have the same crispness and clarity around commission. But I do think that's what's being proposed, Raj.
Absolutely. We currently have a clinical strategy board which sets out the commissioning intent, if you like, on behalf of the 12 CCGs in shadow form. Now, there was an anxiety at one point about what happens when this governance arrangement around the 12 CCGs expires at the end, when the PCTs come to an end. But the 12 CCGs are working exceptionally hard, as we speak, to create an enduring governance arrangement beyond April next year, so that when you as a provider board are functioning, effectively you get to speak to the commissioners as a single commissioner on important and Greater Manchester issues. And I know already that a number of the providers that come to the Clinical Strategy Board are quite relieved and satisfied that they've been able to come to a single commissioning board instead of having to go to 12 different CCGs on parochial issues. And where that's worked, it's worked exceptionally well, and I hope that we will make that endure.
So I think what Mike and Raj have said actually do match each other, and I think that is absolutely essential to make it work. And this is what's happened by the system. The two bits of the system need to work together to achieve the outcomes.
You said you're going to involve patients. There's currently patient representation on the Cancer Network board, and I'm just wondering how the patient's going to fit in at that level, not just a consultation exercise, but actually take part in what goes on at that level.
So I think it's at all levels.
Sorry. You were saying you're setting up a new sort of board.
Yeah.
Well, was the patient going to fit into that?
At that level and at the pathway level and throughout the whole enterprise, if I got anything to do with it.
And all CCGs are certainly taking quite seriously how they engage the public and the patient in decision making. Certainly I know that even at practice level this is happening in different ways because of the way that enhanced services are working. And certainly that I indicated earlier that there are different ways of gathering that intelligence through the consultation itself, but we'd want to do it through a formalised route as well. So Ian, do you want to?
It's just again to mention the authorisation process that we're going through. One of the domains of authorisation for CCGs is around engagement, and particular engagement with the public and patients. We're seeing some quite innovative ways of actually doing that, and certainly as the 12 CCGs, we're involved with reviewing other CCG development, and we're actually going around picking up those ideas as we go along, and hopefully we will begin to see those being introduced into our own localities.
So if I can just add to that, I mean, my experience is that, and I know there are a number of people from Macmillan in the room, that Macmillan and other organisations, but principally Macmillan in my experience, have been extremely helpful in helping us to think through how we might achieve that objective. I think he's, you know, I think it needs to go beyond having a patient on the board, as it were, to thinking more innovatively about how these things are done. And there are organisations that can help us do that. I'd want to make use of that.
Hi, I can just ask a quick one. As part of the Cancer Network, there's actually 3 Cheshire CCGs, South Cheshire, Burrows and East Cheshire, and I wondered how we'd be fitting in with your plans.
Right, okay. At the moment, the Clinical Strategy Board does represent the 12 Manchester CCGs, and I think what will be important is for us to either co-opt for the specific issues or just have a standing invite to the Clinical Strategy Board. I think we'll have to do something like that. But it just makes sense, really, yeah.
Julie, can I just make one? It's a slightly separate comment, and I think one of the reasons I think we can be really positive about how we move forward. We talked earlier about Chris's role in terms of leading on the Cancer Board for us. With Chris also being the main lead for MAHSC, with all the work that so many colleagues in this room have been around developing our AHSM across the patch, I think probably for the first time we've got a mechanism for cancer that pulls together patient care, teaching and training and research. And all that comes together under the one mechanism. And as we're all aware in the NHS, we're real swines for creating parallel structures and you're never quite sure where a decision should be made. But I think we now have one mechanism that will draw all that together.
Are we done? Will you join me in thanking them?